4 choices of treatment. 1 minute. Achha. So make your decisions. Thomas's splint, put a spica, second choice. Third choice is to put any elastic nail, either enders or tens or rush nail, any of the nails. And fourth choice is an external fixator. Okay, keep your hands ready, buttons, and your time starts now. Okay. So 5% Thomas's splint, 49% spica, 39%, a very big majority wants to put an elastic nail, and 7% is for external fixator. And thankfully there is no option. No one has voted this time option 5. So anyone from group 2, anyone, raise your hands. 1, yeah. Why did you select spica? 4-year-old child. Why not nails?
In this fracture, the reduction is there is no shortening, and the stability is there, acceptable alignment is also.
And you think it will work, and that's the right sort. Anyone from group 3? Anybody? Raise your hands. Anybody? You voted. Come on, yeah. Somebody, yeah. Yes. Yeah, 4-year-old child. Yeah, tell me. Why did you select? Why not spica? Why nail? Height of the child, a normal Indian 4-year-old child like this. Normal Indian. Yeah, no, normal average build 4-year-old child. Oh, no. So you think 4-year-old child spica is difficult? Yeah, that's your choice. No problem, no problems. So, this was a debate actually which took place on Facebook, on IORG website. And what I will tell you, from the people who have responded, I don't know if any one of them are here, but among people, there were almost 39 responses. And only one person said should be given plaster, and rest everyone said they should be treated by elastic nail. This is not what is a recommendation, though. So it's a debate, it's a choices we have to make. And to help you make these choices, we have certain people here. I invite Swapnil Keny, who's going to talk to us about conservative management. And then the man from Ganga, he's going to talk to us about when to put nails and when not to put nails. And then you have 2 people, Premal, who's going to show how to put enders nails, and Sandeep, who's going to show us how to put elastic nails. And after that, we'll have a very interesting sort of case discussion, which will consolidate, and by end of the session, I feel all of us it will help us to decide in which case what we should be doing in fracture shaft femur across different age groups. So first, Swapnil, you start and tell people how to apply a spica. So, in 4-year-old child, he'll show you how you can apply a spica without any problems. Swapnil.
A very good afternoon to all of you. First and foremost, I would like to thank Dr. Premal, Dr. Sandeep, and Dr. Taral for having me here. My mandate today is basically to speak on the conservative management in younger children, preschool, or children who are going to pre-primary. Now, the first thing which we need to understand is why are young children more susceptible to fractures of the femur. Now, if you look at this graph, you will find that 2 things are happening here. One is that the weak woven bone remodels to a strong lamellar bone by the age of 7 years. So before the age of 7 years, even certain trivial falls can cause fracture shaft femurs in young children. The second thing is that the diameter increases over a period of age. Because of this, the moment of inertia and the strength of the bone increases over a period of time. Now, in the neonate, essentially birth injuries are common. One has to rule out metabolic bone disorders. And usually these are stable fractures because of low energy injuries, and they can be treated with a Paulick's harness and maintain the position. But then, if you think that Paulick's harness is the panacea for all neonatal fractures, you have to actually think again. Because literature recommends that there are certain indications where actually a hip spica is given in these neonates. And the indications are spiral fractures of the proximal femur with the proximal fragment inflection, significant shortening of more than 1.5 to 2 centimeters, and more than 30 degrees of angulation. This is a case given by Dr. Sandeep Vaidya. This is a young neonate with a fracture. If you see here, there is a significant amount of overlap. There is a significant amount of angulation. It was treated with a Paulick's harness and it eventually remodeled. But till the time it was remodeling and the child was gaining length, there was a significant amount of stress on the part of the parents as well as on the part of the treating surgeon. Now what about hip spicas and femur fractures? They are considered to be the best options for managing femur fractures in children below 6 years. That's what the literature says. But there are certain conditions which apply. There should not be more than 2.5 centimeters to 3 centimeters of shortening. A massive thigh swelling is a contraindication. And other concomitant injuries like this child who had a polytrauma, right-sided fracture shaft femur, significant overriding, and shortening with a hemothorax. In this case, probably you would consider something else other than putting a hip spica. Now, hip spica can either be done in the emergency room under sedation. Now, these are usually the younger children up to the age of 2 years, minimally angulated with minimal amount of shortening. Like this child who didn't have a shaft femur, but this is a distal third femur. And I have put the spica basically in a position of comfort because I knew that this will not displace. Over a period of time, it has remodeled. So essentially, this was done without anesthesia in a position of comfort and the child healed over a period of time. Spica has to be given in the operating room for angulated and displaced fractures of the femur. And these are the indications for early spica. Now, essentially, what is commonly followed all over the world, and most centers do it, is the technique of 90-90 spica casting, which I don't use in my own practice. But essentially what you do is you apply generous padding over the popliteal region and the bony prominences, apply a long leg cast, mold it very well, try and correct the varus at the apex of the deformity, and put it in slight amount of valgus because these tend to collapse in varus over a period of time. And then you complete the spica to a 1.5 spica. So this is basically the technique which has been described by Flynn. A case in point is this child who came to us 2 weeks following injury. He had a head injury, he was in general surgery side, essentially seen by an orthopedic surgeon later, put in a spica, the spica broke, there was significant amount of varus. The child was referred to us. We decided not to do much, but just the fracture was gummy, so we just decided to correct the varus to a neutral position, and eventually this remodeled over a period of time. This is the 6 months follow-up. Now, what are the acceptability criteria? And this is something which you have to remember. Below 2 years, 30 degrees of varus valgus, 30 degrees of anterior-posterior translation, and 1.5 millimeters of shortening is acceptable. Between 2 to 5 years, it is 15 degrees of varus valgus, 20 degrees of anterior-posterior movement, and about 2 centimeters of shortening. But there are certain problems which happen with hip spicas. The first is skin problems which can happen, and this was beautifully described in this paper in JPO 2011, and they have picked up certain predictors. The predictors being age less than 2 years, more than 40 days inside a hip spica, and child abuse if it is considered as a mechanism of injury. These are the children who have skin problems and hip spicas. The second and more common problem which all of us face is overriding of fractures inside the hip spica. And Thompson has described a beautiful test called as a telescoping test, where under anesthesia you try and do a telescoping of the fragments, and if there is more than 3 centimeters of overlap, then statistically there is a 20 time higher chance of an unacceptable shortening as an end outcome. And hence, when there is more than 3 centimeters of translation, you have to look at some other modality. Like this case, it was a grade 1 puncture compound, overriding of the fragments, and in this case 4-year-old, but we were pretty certain that we are not going to get any close reduction, so we had to undergo an open reduction and with a fixator. Compartment syndrome has also been described in a subset of patients, and this has been done by Dr. Scott Mubarak, and this is the only paper which is available in literature as of today. And they say that in the 90-90 spica, at times 3 mechanisms are acting which can cause compression syndrome. Essentially, when you apply the spica, if you apply too much of calf pressure while giving traction, there can be a significant amount of swelling of the calf muscles. The second is hypoperfusion of the calf muscles at times because of limb elevation. And the third is, once you apply the spica and the child is out of anesthesia, sometimes the tissues actually slip proximally and they can impinge against the corners of the spica, causing compartment syndrome. And hence certain alternatives have been described, and this is what I use the technique. Basically 45 degrees of hip flexion, 30 degrees of abduction, and 90 degrees of knee flexion. The heavy child is always a challenge. More than 40 kgs weight, wide proximal thigh girth, tapering thigh-calf axis, and an inherently unstable fractures are absolute contraindications to applying a spica even in the younger child. Like this child, 5-year-old, 55 kgs, you can see that this is an unstable fracture. There is a large medial fragment which is there, and we are pretty certain that this is going to displace in a spica, and hence some other modalities have to be used. The last point is essentially about gait disturbances, and this is a paper of a heterogeneous group of patients which were compared between an external fixator and a hip spica, and they found that there were persistent gait abnormalities in children who underwent hip spica for a period of 2 years following the healing. And this is something which we need to remember and tell the parents that there may be these problems which will eventually sort out. So what's the message for today? The message is loud and clear. You don't really have to throw away the hip spica, but you also have to use a lot of caution and a lot of care while using it, and then thy shall cure. Thank you very much.